I'll make you the co-host.
Oh, darn, she's recording us.
I feel the same. Don't worry.
Let me set this up here so that I can still see you. All right. Can everybody see? I see thumbs up. All right. There we go. All right. So I've taken the liberty of now referring to buprenorphine as the most misunderstood medication of the century, possibly of all time. I don't know. It's tough to see everyone when presenting here, but any thumbs up or thumbs down or kind of, yeah, there's just a lot of hoopla out there. And you know, it doesn't end with just some simple facts. Like things we'll go over today are kind of going one little fact at a time, and you always got to take into account the totality of a situation. So I wouldn't want you leaving this thinking, oh, he said that, and it's like, well, just remember he said that, not just one thing here or there, and anything that anybody else interjects with or says or any of that kind of stuff too. So, all right, looks like the chat. Michael's saying which century. You know, when you make a title, sometimes you're like, yeah, this century, and it's like, yeah, it's only 2022. It feels like, 2082, but maybe both. I don't know, but maybe leeches had to go in the previous one. I don't know. We used to do things differently back in the day. So, all right. So onward we shall go. And if anybody didn't see the random announcement, I know I don't get out much, but I just checked the World Wide Web before this started, and apparently a bit much better title than I usually go with conversationally, but our governor has declared state employees are off on Friday. So there you go. Starting out with some positive stuff in case that applies to anybody. Learning objectives. We're going to go over buprenorphine, all of it, and basically a respect for its pharmacology and all the FDA approved products, what they're approved for, what's going on. By golly, a lot of things that everybody on this not call but Zoom know and utilize all the time, but just kind of talking through it as a group a little bit more too. So there's a couple of pictures out there that I think are perfect for talking about buprenorphine, this being one of them. Is it a bridge? Is it a bunch of boats? We know the facts and they get convoluted here and there. Perspective and situations are extremely important, and where someone is in their journey as well. Maybe they're earlier and it really, really looks like a bridge to me. I don't know. Maybe somebody's a little bit later on and it's like, I don't know how you get a bridge out of that thing. It transmorphs over time. So a couple things that we'll go over, just some of the basics here. One of the tricky things with echo is you don't know if you're going to have 10 minutes or an hour. So, if we get these cases of rubber and it's like, good golly, God bless all presenters, not this guy, but everybody. But origin, mechanisms of action. I have a lot of abbreviations here, so I'll say some of these here. Mu receptor affinity for the opioid receptor, metabolism, half-life, dosage, morphine milligram equivalent factor, the infamous ceiling effect, adverse drug events, side effects, microgram, milligram, misuse, diversion, abuse, all that stuff, cost and access as well too. Those last two get lost in the shuffle a lot. Just share. Oh, all right. I was just checking the chat, but people are looking to rename themselves. I can keep going and call yourself whatever you want there. All right. So as far as mechanisms of action, so here's just a chart going over, right at the top, the partial mu agonism is probably one of the, not one of, but the most misunderstood thing we've got going as far as the intricacies of a mechanism of any particular medication or substance for that matter. Buprenorphine also has some antagonism at delta and kappa opioid receptors. And this whole ORL thing is kind of debated on whether it'll be a new term here or there. I wouldn't get lost in the shuffle there. It's really all about that partial mu agonism. I also took the liberty of adding in binding affinity for each of these receptors or mechanisms as well. We'll go into that a little bit deeper in a couple minutes. But this partial mu agonism thing is, in a philosophical approach, we are the humans, we make the words. And it's like, if we just made up a different thing for partial, it provokes anyone to think, typically outside of this genre, to think, oh, partial must not work that well, right? I'll quote Dwight from The Office. I'm originally from Scranton, the Electric City. False. It really has nothing to do with that. I don't know about you, but I have struggled to teach this to others. And I was attending a conference a year or two ago during the height of the COVID times. And so it was virtual. And I started doodling because I can't pay attention all that well, and tried to figure out how to teach the darn thing. So that's what the next 2 slides, I believe, if I know what I put together here, we'll be going into. But big disclaimer, this is not the actual mechanism of action. Okay, this is totally just made up by yours truly to try and help us get others to wrap their heads around what's up with the partial agonist. This was originally on a little post-it note, and I said, well, we can make that look a little bit better. So I started making boxes because I can't even make stick figures, but apparently I can make squares and rectangles. So I figured that part out. But anyways, pretty straightforward for a full agonist. We're going to see, I believe it's a rectangle fitting into the rectangle receptor there, and it'll do that. Partial agonist, about the best way to conceptualize. Again, this is not exact. This will not be in a textbook. This is just wrapping people's heads around the effects that I've made up here on the left based on what actually happens. So you can see that if these substances in the various forms of green were to touch any of these blue parts, the idea here, what I'm provoking, is that those effects would happen, or at least have a chance to happen. So edge of your seats, you paid for the whole thing, boom, they fit. So full agonist, you have a chance for all of these effects. The more that it's touching, in my made up little world here, the more the chance for it to happen. Things of note with the full agonist, it's touching the respiratory depression a little bit, but if the dose was a little bit heavier, pushing it deeper, again, just philosophically, higher chance for that. But it doesn't mean that someone's going to get respiratory depression from every opioid at every dose. Of course not. I hope it's the second silliest thing you heard today. But what's up with these partial agonists? Because eventually we're going to talk about ceiling effect and its nuances. But there's this idea out there that like, oh, there's a ceiling effect, so there's no chance for respiratory depression. Well, we know that there is. I mean, think of a kid. I mean, my kid licks one of the buprenorphine tablets films, go to the ER. Maybe my wife and I will debate on the ambulance, or me driving really fast. It's a thing. It would happen. Could happen in other instances too. So what I've made philosophically here with some PowerPoint art is that triangle is just touching it, like barely. Small chance, but it's touching it. So maybe. And along the way, there are the other effects, of course, like analgesic effects, euphoric effects, nausea, vomiting, and all the rest as far as side effects go. All right, so that was my attempt at making some drawings or whatever. But again, that's not the actual mechanism. That's just kind of trying to wrap the heads around. All right, so I had fun with those boxes. So I had some fun with these as well, too, I guess. These are more charts along the way. Don't get boggled in the numbers here. Seriously, for our conversation, it won't even matter. I've already highlighted the part that matters. New opioid receptor affinity. 2 boxes here, 2 charts. One's alphabetical, not going to help us out here. Towards the green, the high to low affinity. So this is just the magnetism to the receptor. Nothing to do with the effect. Affinity, there's a textbook, a receptor affinity, textbook wise would be a thermodynamic chemical attraction to the receptor. It's its magnetism to the receptor, in other words. However, it's thermodynamic. It is not effect, it is not intrinsic activity. It's just the magnetism to the receptor. So as we could hopefully see here, there's a listing of a lot of prescription opioids, a couple other ones thrown in there too. And buprenorphine, sans sufentanil is at the top. And there's not that many sufentanil products readily available for us. So buprenorphine is really up there, meaning that it has more of a magnetism than everything else underneath it on the green chart there. Really important to keep in mind for future topics here as well too. I have a couple other tidbits just written there from you guys. Eyes probably already went on them as well too. The values that are there are K values, not to get too technical, but the smaller the K value, the higher the magnetism. course, everything is reversed. It's just how we roll. So, all right, metabolism. This is a more congested slide than I usually appreciate, but lots of info when it comes to metabolism for bup. So primary is 3A4. Anybody think of any drug interactions off the top of your head? Yeah, take a wild guess. You probably got not a 50-50 chance, but a lot of them. The reason I included the not the picture, but the chart here as well is to say that not only is buprenorphine obviously pharmacologically active, but there's also affinity and effect for various responses for the metabolite of norbuprenorphine. So, you could use the mouse here. Remember that now. So buprenorphine down here, this is receptor affinity. So will it attach? But over here, effect is where we're really talking, where buprenorphine analgesia, and here the metabolite 3A4 norbuprenorphine, that's a methyl group. Yes for analgesia, yes for respiratory depression and sedation too as well. So it's not necessarily the buprenorphine, it's the metabolite. I find that interesting. And then the secondary metabolism also leads to much more fancier terms there. It just metabolizes it more, changes the chemical a little bit more. And there's various effects there as well too. A little bit similar when you're talking about the glucuronide longer version there too. But usually what we're talking about is this guy right here. Norbuprenorphine is the metabolite, and that's where we're seeing these three effects here that are of concern, or of benefit or concern, depending on the situation. So that's a big picture there. So 3A4, I had a conversation with a gentleman at an airport restaurant. He was utilizing it as a bar on a Sunday morning. I was coming back from a pain conference. And as soon as somebody figures out you're a pharmacist, of course, you're going to review all their meds. And the bartender gave him a different beverage. He ordered like an orange juice and something or other. And they gave him another citrus fruit and whatever the other beverage was. And I just once we were chatting, I mentioned, hey, if that ever happens to you again and they happen to provide some grapefruit for you, especially if you're in Florida or something, that could really affect those medicines you told me about earlier, since, now privy to your entire story. And he was like, why did nobody tell me that before? I'm like, I can't help you with that. It's Sunday morning, we're in an airport and I don't know you, but now, and that's important. Crazy story to go into, but same kind of thing here, where conversations that we could have with our patients along the way too. I have come across a couple folks talking about some possible inhibition of buprenorphine, by buprenorphine for these other CYP450 enzymes, the ones listed here, 2D6, 3A4. There's not a lot of proof out there. I've provided what I can find as far as 2 of these articles here. So, maybe we'll have more information in the future. But big picture here, 3A4 and the metabolite is active, oftentimes more active. All right. Who here has ever played Half-Life, the video game? I have not. I just know of it, but I've never played it. Does everyone at least remember it in existence, at least? Like, the thing was advertised everywhere. Again, I never played it, but we're going to play a game of Half-Life. Okay. Now, remember at the very beginning when I gave it wasn't going over my, what do they call them? It wasn't my disclosures or whatever. It was my hey, we're going one at a time for pharmacological concepts. Half-Life is one concept. We're going one at a time. And we're going to do it with the equivalent of a video game here. So Half-Life, related to frequency of dosage. We've had this conversation, I believe, many a times within this group, but there's always different folks in the group too. So I can just pick on a couple random medications. And of note, sublingual half-life for buprenorphine, about 1.5 days. So lisinopryl's half-life is about a half a day. So, it takes 5 half-lives to be removed from the body. But you got to be concerned about whether you'll hit the threshold for effect along the way too. So anyways, half-life of lisinopril is a half a day. So we dose it once a day, just kind of calibrating along the way here. And I did just check the chat. So apparently a lot more people have played Half-Life than have not, I think. Anyway. All right, so lisinopril is once a day. It's got a half-life of half a day. Captopril, however, same class of medicines, another ACE inhibitor. Both of these so far, the go-to thing that makes us pharmacists look smart, and half the other folks in healthcare too, is it can cause a cough. It's like common sense when it comes to meds. Happens to us as patients all the time. It's like we forget everything we know. Anyways, half-life is less than 2 hours, so 1/6 that of lisinopril. So it's dosed 2 to 3 times a day. Going all approximate here. Oxycodone, let's kind of amp it up and get into at least pain management, maybe. Half-life 4 hours, so dosage every 4 to 6 hours. Buprenorphine, maybe this is going to kind of crash the half-life game here, but half-life is a day and a half, dosage once daily. Technically could be less frequent, but that would only be concentrating the half-life when you take the totality. But then, of course, the question becomes, as I know you saw coming, what's up with twice a day, 3 times a day, or even 4 times a day? I personally have not seen any requests or utility of more than 4 times a day. But if you have, chat away. That's what we got that typing thing for. It just gets a little bit confusing. Because if you're looking at the half-life, you'd be thinking, my gosh, what would you need more than once a day, really? Well, a little bit more to take a look at too, though. So here's our on the left. It's just a single dose, which is not reality, but we're going to build up to reality on the right here. The overall idea here is that, the person takes the dose. In this case, it's 16 milligrams of buprenorphine. And over time, there's going to be less of the medication, obviously, in the body. The question becomes, well, what's the threshold for efficacy? And there's no line on here because there's no reference necessarily for that. However, in the background, in reality, there's going to be a redosing. Let's say it's every day. So as there's a little bit less, another dose that cranks it back up, as you see, going from the red to the fuchsia or something. I'm not really good with colors. And then you end up over here in blue. We'll skip red to blue. We can all do that, of dose upon dose. And eventually it just kind of peaks off because at some point the body's got this on as long as the adherence is there. This side is more of the reality, of course. But when taking, it's not the totality, but both the half-life and the cumulative along the way, it really begs the question of, okay, well, how many instances would there be a realistic approach for using more than once a day? You and I both know there are instances, but they require conversation and documentation in reality. Those are conversations I know others even in this group have had with very high level folks, whether in our clinical programs, organizations, or even on a federal level, if not state level. And it gets tricky, just so tricky along the way. All right, so if that was controversial. Maximum recommended daily dose when you bring out the package insert and get out the magnifying glass to read the -15 font, we'll say 24 milligrams. Just to look at more than a package insert, you've probably seen some of these before here and there, but here's cherry picking one reference to show the brain scans of seeing what's going on at the receptors. But again, that's not necessarily effect. So there's a little actually a big caveat here, a little asterisk for us. At 16 milligrams, you're seeing those receptors being saturated. Does that correlate directly to effect? Typically, but not always. But the point being, would it really be needed in a large percentage to be utilizing more than 16 milligrams a day? Now, we've had cases in this echo alone where there's been questions on that. I think there was like an on the fly one a couple of days ago, and we're going to go over that in 2 weeks from now or whatever. So think of this even 2 weeks from now, because this is textbook more so, but we've got to apply it to real life with our patients as well too. So, all right, the MME factors. So I won't pull everybody, like them, love them, or hate them. They're around. In fact, I've those of you that know that I host a podcast, the Pain Pod, and on the Pharmacy Podcast Network. My most recent episode, it debuted about 2 or 3 weeks ago. Is the only guest I've had that took more than an email to ask to come on the show. It took me a year because it was the CDC. So the CDC opioid guidelines are in the process, the final steps of being updated. And I got one of the primary authors. He was the PharmD primary author of the 3 or 4 folks. And we had a very good conversation going over that effort overall. So feel free to check that out. painpod.us. Not cool enough to have .com. That's like some big company. But anyways, MMEs are a big part of that effort as far as those guidelines, and that's over in the pain world, but obviously things overlap. Conversations that many have had, and I will get to what in the world I mean by these pictures. I promise I'll get to it. Those guidelines were released in 2016, March of 2016. Still pretty cold around here. ME factor for buprenorphine at that time was published to be 10. A lot of people across the country were kind of wondering with that. It just didn't fit into a lot of patient cases overall based on multiple references. So in 6 months later, in September, I was hanging out in the Cosmo in Las Vegas with a couple thousand other people at Pain Week. And I got a consult. And on my iPhone SE, the first one, which is like the equivalent to AOL dial-up now from 1990, whatever, I was able to find multiple references while sitting on one of their luxurious couches right after one of the CE sessions. I took the liberty of sending those to some CDC contacts. And magically, less than 3 months later, with a lot of other people doing very similar things, the MME factor was updated to 300% of what it was published originally. And we want to build trust. Yet I had a good conversation with one of the primary authors. Go figure. It's all about just respecting each other. So the MME factor was 30. Now today, I'm sure many know you can't actually find the MME factor. The last published was 30. And now to avoid as an attempt to avoid any stigma, it's just not out there. Because if you multiply 16 milligrams, like we just talked about, by 30, you get 480, which is like cataclysmic compared to those CDC guideline cautionary levels. And that will create some stigma or at least confusion. But we're clinicians and we need to know the math. I mean, we have way better phones than we had back then. Gosh, what I can do this year compared to 2016, man, I haven't got one of those pros now. The heck with SE. That was confusing along the way. And here we are today where it's like, oh, it's just not published. Well, like, what do we do? So highlighted the last published here for us. First time I went to Pain Week in that hotel, I walked in and was like, what is this place? And now I'm like so used to the posh environment. One of the conundrums, one of the articles I did not find in that wonderful hotel was this one. Turns out before that guideline was released, vets already said, now granted, this is in JAMA, it's just a thing talking about some cats and dogs, and they're like, yeah, like buprenorphine is like 30 times the potency of morphine. If the vets knew, how did... Can't say anything nice, don't say anything. No, silence it is. And there's other articles, they're out there if anybody ever wants to see them. But anyways, at least we've got our heads wrapped around those things. Now it's 30 and it's unpublished. All right, so respiratory depression ceiling effect. Actually, I don't have to worry about time. There's no case today yet. So partial agonism, I tried my best to illustrate that with boxes and all that. But bigger picture, a basic pharmacological principle is a dose response curves. So here we see the response, the effect on the vertical, on the Y, on the left, and then the dose horizontally on the bottom. The tricky thing is every response has the propensity for a different dose response curve. Depends on what you're looking for. They can overlap, but most likely will not. So the question here becomes, well, is the ceiling effect for respiratory depression, or is it analgesia, or is it perceived as everything? Typically, the perception is respiratory depression. But again, there's instances where we have to watch with that because it's not infallible. And here is part of the package insert. Oh, first time I'm reading the pronunciation. That's interesting that it has OX in it. It's like, ooh, surprised they didn't want to not have that look almost like oxy. Geez. Anyways, keep it away from children. It's the first thing in the package insert, yet there's a ceiling effect. Oh, well, and that's where things get murky. So we've got to keep that in mind overall too. All right, side effects. So it turns out buprenorphine is a medicine, so it has lots of effects. We humans say that, and clinicians alike, we say, oh, this is the intended effect, and these are the side effects or adverse drug events. In reality, it's just the effects. We're cherry picking what we want. But a couple recent things that certainly caught some limelight as far as side effects. There's, oh my gosh, if anybody else goes on LinkedIn, you probably don't go more than me, according to as my wife calls it anyway, on there a tad bit too much, but whatever. I did post today, so she's right. Day ends and why. A couple months ago, we had, I don't think the date's on here, but a couple months ago, the FDA, there was the headline that came off. The FDA warned about dental problems with buprenorphine medicines in the mouth. So they were talking sublingual and buccal. So basically, we want to remind our patients or inform them to rinse the mouth, swish and swallow water after utilizing those particular products, and apparently also to wait an hour before brushing teeth. That wasn't information that was really covered in the past. Looking online on social media, there's a lot of movements out there of people trying to bring lawsuits because no one went over that because it wasn't something that was with information that was readily available out there. So that gets tricky. As far as adverse side effects, buprenorphine product up the top right here, pulled right from the package insert, sweating, insomnia, things. It's almost like we have some overlap there, even if there was withdrawal or whatever. But those get highlighted along the way. As far as the combination products, things that stand out there, again, that's sweating, insomnia, peripheral edema. That's one. Folks, feel free to chime in. I feel like just based on observations, and I can't remember if it was conversations as well here, but it's conversation somewhere. Folks are seeing that a little bit more than I think expected. So just something to keep in mind as well. We love talking about serotonin syndrome, so I might as well just throw that out there. There's case reports there. I guess there's 3 references with it as well. But that's one of those where it's just, again, going over the simplicity of what people should look for and how to react, where I know even in my clinical setting, I always get oh, Mark, what is with your people? And always bringing up serotonin syndrome. I believe I've said it here before too. It's like, if somebody feels like they have the flu and it's a Friday, don't wait till Monday. Just get in touch with somebody. We don't need to put it on I forget what that one movie says of the different levels, but mock level, whatever. Just in case, because odds are it's not going to happen. But if it does happen, you want the person to know what to do. So, all right. So that's kind of an updated nutshell there for side effects. General dosing, abundantly obvious in the settings here, but of course, just a reminder: micrograms, pain management, milligrams, opioid use disorder. And oh, by the way, folks with opioid use disorder can have pain too. Car accidents happen, broken legs happen, anything happens. We're human. So, that's like a little add-on to the FDA approvals there as well too. Here is my Facebook doctorate slide. I believe I alluded to this earlier. So on the left here, we have the MAT products or product here. This one happens to be Suboxone is labeled. The MAT dosing here, we'll say 16 milligrams. MMEs per day there is 480, going on the last published MME factor. No warnings. The pain product, however, this one, Belbuca, the other one, the transdermal patch has it too. The dosing in this one is 900 micrograms. The MME is 27. So 27 compared to 480. And the 27 has the black box warning for watch out, respiratory depression, addiction, everything else. Interesting. Now, obviously, the addiction part wouldn't be in the other one, but still. As far as the respiratory depression goes, that's interesting. So that's just conversation, I guess. So here's a half decent reference of what products, specific products are out there as far as the different specific doses and what their buprenorphine equivalent is, as per each of the manufacturers and or studies really. So 2 tablets, 1 film, and their respective doses here. Bunavail was discontinued. That's by BDSI. Oh, well, typo. Back in March of 2020. Pretty sure everyone's aware of that already, but just for the sake of completeness, mentioning that as well too. So we have all these different products, but it really comes down to this, the overall idea of looking at 1, 2, 4, 8, 12, or 16 in the big picture. Kind of more of a reference thing. All right, in case we're getting a little boring there, let's amp this back up. Abuse potential. So buprenorphine is a controlled substance. It can be misused, diverted, abused. I believe everyone has to agree with that by definition of what a controlled substance would be even. But here I'm going to cherry pick from package insert again. I'm purposely going with using something like a package insert. I think it's the 3rd time now, just to keep things so simple. Obviously, the more complex references have the same things. But as quoted here in the PI, many but not all post-marketing reports, so real life, regarding coma and death involve misuse by self-injection. This is the buprenorphine with naloxone, so it's still being injected. And in fact, folks are also utilizing benzos and other CNS depressants. Clinicians should be aware that some abuse buprenorphine naloxone combinations by the IV or even intranasal route. Now, in 2022, this seems to be more understood, but for a decent number of years now, we've been increasing our awareness of that. But this is, again, in the package insert, this is coming directly from the manufacturer, originally saying that folks are going to abuse this IV, even though the naloxone is in there as a feeble attempt to block that from happening. But remember that chart, there was the green one, and I believe it was orange for the mu opioid receptor affinity, and buprenorphine was at the top, except for sufentanil. And that's because the buprenorphine is going to do more of that receptor interaction than naloxone. Now, it turns out our human bodies, of course, have lots of the receptors, so there will be naloxone affecting some receptors, but there will still be enough receptors for the buprenorphine as well, too. And that's why we're seeing that. So I recently saw this, I think it was at the National RX Summit, so prescription opioids and heroin and everything else down in Atlanta earlier this year. And it really, I think, hit home. It's abundantly obvious. And I first rule is know your audience. So I knew you guys. But to send the message to others, I think is really important as well, too. So swipe this again and use it everywhere else. But, a lot of the headlines, a lot of the conversations are always talking about what's over here towards the left and the red and the green. Here they're saying a little bit over 200,000 felt they needed treatment and made an effort to get treatment for, opioid use disorder, substance use disorder. And then 737,000, so about 750,000, felt they needed treatment and did not make an effort to get the treatment. But that is so microscopic compared to those that didn't even feel like they needed treatment. Now, you might be confused. You're thinking, whoa, is he talking about tobacco smoking, vaping, and e-cigs? Or is it about, it's synonymous across many of these specific SUD situations, of course, here too. And there is a lot of overlap, as you can hopefully see towards the right there with, alcohol use, illicit drug use, marijuana use, and the list goes on. We are all fluent with this, but that part there on the left is just really, I don't know, I'm a visual learner, so if you guys ever want to get through to me, it requires pictures. But it just the vast majority of that is folks just not even being there yet. And here we are talking about the nuances of buprenorphine along the way there. Let's see here. Looking through some of the chat here, half-life comments. Any thoughts on concurrent buprenorphine gabapentin use regarding cost benefits with potential interactions? So, of course, right off the top would be the sedative obvious interactions overall. Gabapentin, there's a realistic concern with it, and it gets a bad rap too. Here in our state, we started tracking gabapentin-related overdose deaths just a couple of years ago. if anybody knows exactly, I want to say about 6, 7, 8 years ago. And it was immediately reported, oh, there was an increase. Well, if you're not tracking something and then there's anything, there's an increase. I mean, that's not even math, that's just common sense. And also, as I highlighted earlier, related, meaning that there's other stuff involved as well. Not always, but often. Now, the street costs are going to be different, of course, even when it comes to gabapentin. It just doesn't have its it's better stockbroker, I guess. And the interactions are still going to be there. It won't. It's more in the sedative overall sedation there. We are one of, I believe it's 7 states. It's between 5 and 7 states that have gabapentin as a controlled substance in our state. And at least when it comes to medications, you go with the more stringent law. So our state says yes, gabapentin, us, Kentucky, and like 4 or 5 others. But federally, it is not. So, across the border and all of a sudden things are different. Things to keep in mind overall in that regard. Good question. I forget who asked it. All right, so kind of getting towards the wrapping up here. So this is that slide I had with making the hypothetical mechanism of action. I mean, totally made that one up. This is even out there more. The prices are constantly changing in our healthcare system, and they vary a lot. So this is an approximation of taking a look at things at a moment in time and rounding off. There is absolutely no need to have decimal points in this kind of conversation here, but this one single little chart here provokes a lot of discussion when you're talking about interprofessional well outside of healthcare. Where I'm going with that. So let's cover the basics here. Of course, buprenorphine solo ingredient products. Now we're in the healthcare system because your mind is immediately going to go into the opposite. But we're in the healthcare system. Buprenorphine solo ingredient products are the relatively least expensive by a decent amount, really, if you were to compare it to the films. The next same formulation tablet would be buprenorphine naloxone tablets. And they are, I don't know if it's the proper term of slightly more. It is like 33% more, but it's more expensive. Then you get to the buprenorphine naloxone films, brand name. So that's, not quite double. It's 60 compared to 100. Extreme approximation. It might be off by 10 each way. But even if it is, there's still a big difference in price. Now, typically in healthcare, we want to provide our patients the least costly, most effective options. Well, we already went over the nuance of naloxone and how it's not really going to cut it for preventing that even IV abuse and technically intranasal too. So, then you're left with buprenorphine in there, and you'd be thinking, well, why not using the sole ingredient? And then we go to our reservations with our friends. I don't know if anybody on here is with the DEA. I talk with you folks or those folks, depending on who's here, all the time. And there's a lot of trickiness out there. It leads to conversations I've had at least twice with some high-level people in our Department of Justice trying to explain everything I just said to you, typically using the ideas from about 3 or 4 slides that we went over, just to say that this part's not making sense. And they always say, yeah, simmer down there, Marco. Time to sit down. Let's tell you our side. The street still values buprenorphine solo ingredient products, and that's what we have to go by because we're looking at the totality, to steal your own words, of street and healthcare, the overall supply chains. And then I just kind of sit down and say, yeah, I hear you. But this is like the first time in the history of mankind that us clinicians actually have one up on the street chemists, and we need to educate them so that can be recalibrated on the street. Now, I don't know anybody that's an expert in recalibrating street drug prices, but I wish I did, just to have everybody on the same page with the same info along the way. All right, so that's a whole heck of a lot just from going with approximate prices. So last thing on, remember our list, we were going stuff to go through with buprenorphine and then whatever questions as well too. And I guarantee you any questions that are coming in, it's going to be everybody replying, not just this guy. So when it comes to buprenorphine, based on one of the things I was just talking about there of the street perceptions or just external to healthcare supply chains, really, there ends up being these thresholds or really limits. It's debated on who sets them, whether it's a wholesale distributor, whether it's the DEA, and it's this like circular thing. In fact, I recently saw a presentation when they said, oh, well, it's not the DEA, but the wholesale distributors are setting it based on a subset of DEA rulings. I'm like, what are you actually saying? Like, seriously, who does it? We shouldn't need a board game of Clue to figure this out. But with all of that in mind, this is where it hits the pavement sometimes of, various settings sometimes have the opportunity, very few, would have the opportunity to be calling proactively to a pharmacy that a patient says, hey, I'd like to go to this pharmacy and it's where I get my medicines, or it's in my town or whatever, to have a conversation with whatever pharmacist or staff is there to explain, hey, there's going to be one, if not multiple, more patients that are going to be utilizing buprenorphine coming to your practice from me. So what kind of questions you have, all that stuff. Most settings just don't allow for that. I mean, that's beyond utopia. They're out there, but not usually. So typically it's going to be hopefully the pharmacist, or at least somebody on the staff calling saying, hey, I'm ABC from XYZ pharmacy. Just hoping to verify a buprenorphine script. Everybody uses different language, but in utopia, they'd be saying something like, and forgive me, I'm going to read some slides here. I know you're not supposed to, but this one's semi-important. I don't think we fill up prescriptions for your office before, and would like to discuss how we can be sure to meet our mutual patients' needs. Now, somehow folks tend to start taking offense to that, of saying like, oh, well, it's not mutual, they're my patient. It's like, okay, let's move past that first off too, because it's, everybody's taking care of everybody. In this case, this pharmacist is saying, can you provide me a ballpark? I'm a baseball fan. In fact, we've got 2 T-ball games tonight. Back to back. As soon as this is over, we're heading out to the ballpark. It's T-ball. It's like 100 feet wide. But anyways, can you provide a ballpark number for your practice on how many patients are being prescribed buprenorphine, how often, any particular days and times, and the overall care plans? Now, that sounds very like, who the heck are you to be asking that? And I'm being real from this point on. I know we're recording it, but this information, these talks need to be out there. It sounds very intrusive into the, like, I mean, don't you have a corresponding responsibility to check on the diagnosis and making sure that I'm in my right prescribing genre? That sounds a little bit further than that, right? Well, give the benefit of the doubt, and he or she will go on and saying, well, I'm asking because I just want to make sure to stock the appropriate amount, because that could be a little bit of a snafu here and there. And because I need to justify that in writing for our wholesale distributor, because there's another entity on the back end saying, have you asked those questions that we just said there? Now, the wholesale distributor is not always going to be saying, have you asked that? They're just going to say, hey, can you give us any other information? That pharmacist needs to figure out, or hopefully listen to these kinds of talks, to know that that's what's going to be looked for, to know about that. Now, maybe not the particular days and times, like say an office is open, more early in the week or whatever. That's really just on the having things in stock side. But the knowing how many patients will be anticipated to utilize or even currently utilizing buprenorphine in this regard. Those are questions that will be asked of the pharmacy eventually, to enable them currently, and probably for a good number of years currently, to be able to get past those limits that are put on there as well too. All right, let's see here. So another pharmacist on here. I see that because I think it's going to be important. This is saying Tom says it's a reality as wholesalers care deeply about and will cut off pharmacies. Absolutely, it happens sadly all the time. In reality, what we all face, not pharmacists, but everybody in the healthcare plane, you've got their stigma, obviously. So some prescribers, some dispensers, everybody will just say, I'm not touching this genre. Okay, well, if a given town has 10 pharmacies and 6 are like, yeah, not even me attempting. All right, you're down to 4. And if they all have the same distributor, that distributor is going to be running reports these days and looking in and saying like, oh, there's a lot going on in that town. Oh, and we just got sued and had to settle for $1 kajillion. It's a real number. My kid uses it all the time. because we weren't limiting people. So we should probably learn to limit people, right? Oh, we didn't think of that in the lawsuits that are still happening. Interesting. Doesn't seem like chess to me, but anyways, let's see what else. Tom saying access to controls if beep Suboxone ratio above 20% or control non-control 20%. Yeah. So the other there we say DEA red flags. That I don't think I've done that talk here. That maybe I'm signing up for my next one. I don't know. But these DEA red flags, one of totally shouldn't be red. That means stop no matter what, right? I mean, or else you get a ticket or could really hurt somebody. Maybe orange, yellow. I wouldn't say green, but bad. And we have comments here that the DEA says they don't set quotas, and it's just it's fingers going all different ways too. So. All right, so I think I addressed those couple comments there too. The one DEA red flag idea there, really appropriate for talking about buprenorphine too, is what the magical number would be of what percentage of all prescriptions leaving a pharmacy would be acceptable to be controlled substances. And I'll add to that I've seen situations where it's been like 90. So like no one in town has hyperlipidemia apparently. Interesting. Now the extremes we can figure out easily, but setting the actual number would be a little bit tricky. So, All right. So the question would be, everything we were going over, the point of this particular slide and conversation would just be the access concerns and how we really do all need to get along and talk through things. And I learned from experience too. So let me tell you, I haven't always done that all that great. But here we are. And we could have these conversations to go over and at least know why someone's asking this thing. And by golly, if things like this come up, because who knows what the questions will be 3 years from now, just ask, hey, why, out of curiosity, why are you asking that? And vice versa, when providing something, say, this is why I'm asking or whatever. So that slide took a little longer, right? All right, so in the big picture, I think as everyone could obviously know, agree or whatever, buprenorphine improves and saves lives. When utilized as FDA approved with a pharmacological respect. And it's not like you gotta add on that extra little phrase there or anything, because the top part is abundantly obvious and true. But we are dealing with a controlled substance here, and we don't want to get in hot water. And we want to deal with the nuances that are out there, barriers, limits, thresholds, whatever, and be able to continue helping more and more people. Because remember that slide says we got a lot more work to do, because there's a lot of folks that are just like, yeah, I'm still, I know that the cup says caution hot, but I'm still going to risk burning my hand to have my cup of coffee, right? All right, so big picture, just kind of the key points here was, we went over that whole mechanism of action, the idea of partial mu agonists. That's complicated enough. There's some newer terms coming pretty soon for some pipeline pain and I think addiction agents being like indirect or inverse agonists, where they're an agonist, but then they're causing the opposite of what an agonist would do. Oh my gosh. Don't worry, I'll make up some slides for that too. Mu receptor affinity, second only to fentanyl for prescription opioids. 3A4 metabolism, day and a half half-life, sublingual. Max dose is stated as 24, but is it really 16? 30 for the MME factor, which by the way, MME factors are absolutely useless unless they're multiplied by the milligrams. Ceiling effect, respiratory depression, the nuances there. Side effects we touched on, controlled substance class 3, and then the microgram milligram, that Facebook doctor thing along the way. And I'll leave with a quote. So this is buprenorphine circa 2022. I'm the most misunderstood, misquoted medication I know. Honestly, buprenorphine this year. I will leave you with one more thing. This has been complicated stuff, simplistic yet complicated. So let's see who can answer this one first. You get a shiny gold star. I've got nothing else. I'm sorry. Maybe our leaders have something for you, but actually, I'll leave that on there just to.
Thanks so much for that. Really enjoyed that.
28.
All right. Let me just, I've heard 28, I've heard 17. So far, all incorrect. Probably Any other guesses by anybody?
I'm guessing 20.
All right, so we've heard 17, 28, 25, 70. Man, Michael, you're ramping it up there, bud. All of those are incorrect thus far. One or two more guesses. Katie, that's the best one I've heard yet.
Agreed.
A great breakfast. That's the best. So, echoing 70, 14, 25, 20. All right, so drum roll. Let me go over how we figure this out. How do we decipher the bridge from the ship? Remember that other picture? So it's not the fact that it's a cookie, although that'd be a really good breakfast, right? It's how many chocolate chips are on the cookie. So in this one on the bottom, it has 7. So that one, that entity equals 7. It's not the clock, it's what time the clock reads. So it is 2 o'clock on that clock. So that is equal to 2. So we have 2 and we have 7. It's not necessarily the bananas, it's how many bananas. They are each 1 banana. So across the bottom row, we have 2, 1, 1, 7. And then the laws, the rules of mathematics say that you do multiplication before you do addition. So going from the right side, it's 7 times 1, hence 7. So 7, I'm going to go from right to left. 7 plus 1 banana plus 2, 10. The answer is simply 10. And Michael says, this is simpler than beef. Of course it is. I had to end on something to just, get our brains wrapped around something a little bit easier. So the answer here is 10. Anybody got some sad tears and laughing tears? We got all kinds of tears here today. I'm not supposed to make anybody cry, jeepers. All right, I'm going to stop sharing screen here now.
That's awesome. Thank you so much. Again, you're always like really involved in your slides, and I do like that and appreciate that. Does anybody have any questions or just comments about this? Please come in and chime in.
People are so going to want to watch the recording for that last slide. And you need some metrics on how well the recording does.
Mark, I have a question. What do you think about buprenorphine in an emergency overdose situation? Since the affinity is so high and it has a ceiling effect for respiratory depression, what do you think about using buprenorphine, like somebody who has some films or something, to counteract an overdose?
So that's a heck of a situation question there, Jeremy. So what somebody would have to pull in there is, I was yapping about dose response curves earlier. So this would actually be multiple dose response curves for the same response, because you'd have an opioid, whatever it may be. Let's just say it's diacetylmorphine or something at whatever dose causing the overdose. So I believe, and retune me here if I'm off, I believe what you're saying is, would you be able to have someone ingest buprenorphine to then push them off the offending opioid off the receptors?
Correct. You have to compete it away so that
Okay.
then not have the same respiratory depression.
Right. Because the buprenorphine would be relatively less offensive for respiratory depression. So in a textbook, and if I were to make a philosophical slide for that, it would perfectly work out. But in reality, in our human bodies, the affinity isn't necessarily like a little Atari game of pinging things off. It's just when the receptors are there and they're available, who's gonna attach first and quickest and stay on longest. And that's where the buprenorphine comes in. So I would not expect that to work out, because the offending opioid that caused the respiratory depression would already be attached, and it's not typically going to get kicked off. It's going to be like, hey, I'm already here. Keep on going to the many others, and the buprenorphine would. And that might actually lead to a tricky situation where, yes, ceiling effect, but now you have the offending opioid with a less offensive one, but additive there. So that being said, things are wicked awesome when it's not textbook. So who knows what the future holds, but I wouldn't expect that to be therapeutically helpful. And I hope that without a visualization that made sense to at least half of the people. All righty, and feel free to keep in touch, folks, too, anytime. So
Yeah, thank you so much for that question, Dr. Hirschler, and thank you, Mark. Does anybody else? We have about 5 minutes, so you still have time to discuss. But if not, just, let me know. Alrighty, gave it that good pause. Again, please do reach out if you have any questions. I know that's a lot to take in, and it's a great topic, and really do appreciate your time, Mark, and everybody else that came in today. I just have one announcement. On June 27th, Dr. Zhang's going to discuss meth and Suboxone use. So that'll be another good topic to be part of. Thank you so much, everyone. Have a great evening.
Thanks, everyone.